Hello, everyone. Thank you all for joining us today from wherever you are in the world. We hope it's not too early or too late, and we're excited for you to dive in and listen to our wonderful speakers today on this session. My name is Dapo, and I'm from the TASCOP Global Consulting Group, providing technical support for the Congress. So I will first introduce our moderator for the session, Mr. Delaney Hines, who excels in building relationships and forming partnerships to promote equitable health outcomes. He is dedicated in advancing health equity, particularly in cardiovascular and cerebrovascular health and sickle cell anemia. Mr. Hines also serves on the board of the Sickle Cell Awareness Group of Ontario and has a background in supporting health programs at organizations like St. Michael's Hospital and Mount Sinai Hospital. Mr. Hines holds degrees from Carleton University, Western University, and Quantic School of Business and Technology. Mr. Hines, over to you.
Thank you, my friend. Good morning, good evening, welcome one and all. And thank you so much for participating in this session. Just to confirm you're in the right place, this is the benefits and risks of curative therapies in inherited blood disorders. We have a panel of 3 experts. There's a bit of a typo on the agenda, but we have 3 experts here who will discuss the topic of sickle cell disease, thalassemia, and hemophilia perspectives from their own patient advocate / expertise. And joining me in today's presentation, we have Doctors Titi Fasipe and Dr. Ahmed Kabil, as well as Bessie Calabria. So first, we're going to start off with an introduction of Dr. Dr. Titi Fasipe, who will be delivering our first presentation. Dr. Fasipe is a co-director of the Sickle Cell and Thalassemia program at Texas Children's Hospital and an assistant professor of pediatrics and hematology oncology at Baylor College of Medicine. She's passionate about public health strategies that target the psychosocial barriers and health complications of individuals with sickle cell disease. She's been repeatedly appointed to sickle cell-related advisory committees of the Texas Department of State Health Services and currently chairs their sickle cell task force. Her professional memberships include Gansett, as you can all, astutely draw the connection, Heartland Southwest Sickle Cell Disease Network, NHLBI Sickle Cell Disease Advisory Committee, the NHLBI Cure Sickle Cell Initiatives Community Input Panel, the American Society of Hematology, ASH, and the American Society of Hematology Research Collaborative, as well as the American Society of Pediatric Hematology and Oncology. Dr. Fasipe has the unique perspective of relating to and understanding the need for education, community awareness, support, and medical care, as she's a pediatric hematologist as well as an individual living with sickle cell disease. So without further ado, over to you, Dr. Fasipe.
Thank you, Mr. Hines. Very happy to be here, and thanks to the organizers of this Congress. Last year was wonderful, and I hope this one is just as good and better. I'm going to share my screen, and let's see. All right. What are y'all able to see?
Right now, we can see your slideshow, but it's not in presentation mode.
Okay. How about now?
Give me 1 second. Perfect. You're all good to go.
Okay. So in some of our pre-conversation chats, I was going to cover a little bit about the benefits and risk of curative therapies in hemoglobin disorders. So not just sickle cell, I'll overlap in thalassemia a little bit just to give more of the clinical background. And I know Ms. Calabria will go more with the community perspective, which I'm excited to hear about. But so just because you'll hear a little bit of thalassemia, I wanted to give you fair warning. I have no disclosures. And so our objectives today are to summarize the nature of both sickle cell disease and thalassemia and some of the barriers to innovative therapies for both disorders, and then differentiate between the current options that are of a curative nature for sickle cell and for thalassemia. So first, I know this audience is probably a well-versed audience, but just in case there are new people to the room, I just wanted to briefly go over the fact that both sickle cell disease and thalassemia are considered inherited blood disorders. And then they both have genetic mutations of hemoglobin. Now, most of the mutations are mutations in the beta hemoglobin. And so and you can see in this graphic here that hemoglobin comes in both alpha and beta. But most of the issues with sickle cell are, of course, on the beta side, where you have an abnormal or altered beta globin protein, and it makes it behave differently, and that leads to the classic phenotype and the clinical picture of what happens when you have sickle cell disease. Here, I only feature beta thalassemia. It's also a mutation on the beta gene, beta hemoglobin gene. There is an entity of alpha thalassemia as well, which we'll discuss a little bit, but it's mostly going to be the beta globin for this conversation based on the therapies that we're going to focus on. So in beta thalassemia, or any of the thalassemias, you have a problem with the quantity, not the quality. So the hemoglobin works, it's just you don't have enough of it. You either make too little or you don't make any at all. And then there are some versions of thalassemia where it's a combination of not making enough plus an abnormality. So thalassemia is complicated. And so we simplify it. This graph kind of shows it. We simplify it by focusing on what does the person experience? What is their clinical phenotype or the clinical features? And you might also refer to it as things like minor, intermediate, major. And they correlate, minor correlates with not really having a lot of complications, not really needing transfusions. And the further down you go to severity, you end up needing more transfusions. And so clinicians refer to people with major, thalassemia major, or severe clinical features as somebody who is a transfusion dependent type of thalassemia, because they need transfusions regularly in order to have a good quality of life. Now, in the middle group, those that have moderate severity, or they're considered thalassemia intermedia, they might need transfusions every once in a while. Sometimes they need them regularly, just depending on what's going on. And so because of this variability, you end up getting a disease that's not easy to pinpoint. We have a clearer care plan for those with severe, where we put them on almost monthly transfusions for the most part. But if you're in a country that is able to do so, and that gives the best chance. And so that's why it's good that we're talking about potentially curative options today, because you can imagine a lifetime of chronic transfusions can also be problematic. It can help your disease, but yet it comes with side effects as well. And then we won't discuss the variations of how you can get thalassemia, but just know that thalassemia is about balance. How do you balance out your globin, your hemoglobin? Do you have enough alpha hemoglobin and beta hemoglobin to make the right type of partners? And depending on your type of thalassemia, whether beta or alpha, it's all about finding the right partners to match up with. So when you are diagnosed with thalassemia, there are a host of issues that happen that start with your bone marrow. And this is actually the same picture, but I cut it in half to make it bigger. So basically, the bone marrow has a problem with the way it brings out your red blood cells because of the hemoglobin problem. And so that leads to having anemia. It also leads to having other complications in the body that are more than just the red blood cells. So whether it's the spleen, or heart, lungs, liver, bones, and the intestines, all of these organ systems can be impacted. So thalassemia definitely is a great burden. And when you look at it worldwide, it impacts several regions. It's in particular Southeast Asia, the Mediterranean, Africa, but of course we can find it everywhere around the world. So what has been going on with thalassemia treatment? Well, the mainstay was transfusions for those that needed it. There are some medications that can help stimulate the production of another hemoglobin. You see the Greek letter gamma here. This ends up, when it turns into hemoglobin, it turns into something called fetal hemoglobin, or hemoglobin F. And so you could trigger that to try to counteract the fact that you don't have enough of the beta hemoglobin. But this is why we're here today. We're going to talk about transplant and gene therapy as options to help the issues with thalassemia. So I'm going to flip to sickle cell as well to give you a little bit of background before we talk about the curative approaches. So my experience is largely in sickle cell disease, although I do also take care of individuals with thalassemia. And so because I've been studying it for a long time, I'll give a little bit of a deeper dive into the fact that similar to thalassemia, it's a global burden. You find it worldwide. And the darker the color of red in the picture below shows you how many babies are born a year. And in the top 3 countries, Nigeria, India, and Democratic Republic of Congo, it's quite a large number. In fact, about 100,000 babies are born annually in the country of Nigeria. When you contrast that to other countries, such as the United States of America, where total it's in the 100,000 range, or give or take. And so it's not always a common disorder, depending on which country you're from, but it's always a disorder that still gets impacted with disparity. And that's because it's associated with stigma, neglect. And even though it has a lot of interesting facets about the disease that intrigue scientists, it ends up being a double-edged sword, which we'll get to when we talk about the therapies. And so what's the issue with sickle cell? I mentioned earlier that because it's an abnormal protein, it behaves abnormally. It causes the cells to change shape, and you can get a host of problems. And you can see here a summary of some of those problems. One of the more painful things is that in addition to having various organ system issues, you end up having premature mortality. I didn't discuss this with thalassemia, but thalassemia is also faced with premature mortality. Even though they get transfusions, as I mentioned, there's a risk benefit of the transfusions is still not enough to necessarily guarantee a normal lifespan. And so both of these diseases together are important to figure out how do we make a solution to allow people to live longer and have better quality of life. So for sickle cell, that answer started not with just transfusions, unlike thalassemia. It started with, first of all, making sure you know you have sickle cell disease. And so newborn screening, which is not universal worldwide, but it is universal in the United States of America after a long time. And I know in certain provinces of Canada and in certain areas of Europe as well, there's a push for universal newborn screening. So that way you can start education early. And with sickle cell, only a subset of people will need transfusions similar to thalassemia. Instead, a lot of it is preventive measures such as preventing infection and preventing that organ damage with medications like hydroxyurea. And so for both of these disorders, we have a way to maybe prevent some damage. For thalassemia, it's transfusions. For sickle cell, it's maybe hydroxyurea and infection prevention and sometimes transfusions. But how do you take away that kind of devastating punchline, or the fear of the devastating punchline of progressive organ damage and shortened lifespan? Can we actually prevent these more definitively and not just with medications? Well, several years ago, my sister got an email, and she was so surprised because she did not know it was possible to cure sickle cell disease. And to tell the truth, around that time, I had just learned it not too long ago myself. And it's because she got this email from a group known as Be the Match at the time. And now they're called the National Marrow Donor Registry program. And they said, hey, you could potentially be a match for somebody and help them cure their sickle cell disease. And so both thalassemia and sickle cell disease, it was found that a bone marrow transplant can cure them. However, you do need a donor for that before up until a few years ago. And so what does that process look like? So when we say bone marrow transplant, the other name for it is stem cell transplant. So stem cell therapy, and not the stem cell therapy that you go to like an infusion clinic and get, but you want to kind of make it permanent, not just a monthly infusion or a weekly infusion. So that type of therapy, a transplant version of it, is considered a curative approach for hemoglobin disorders, so both sickle cell and thalassemia. And so you need a donor, and that donor, the best scenario is if that donor is a member of your family, a sibling donor, like a match-related donor. But there are other ways to be a donor as well. Well, you take the stem cells out of your donor, either through cord blood, the bone marrow directly, or by almost doing like a extraction process, almost like a reverse blood transfusion. And then you process it, and then you prepare the person who needs it. And the only way right now to prepare the body to get a transplant, because it's not a surgery like getting a kidney transplant or a heart transplant, you actually need medication to get rid of the old bone marrow. And right now that's done through chemotherapy or radiation. And so what happens to people who get a transplant? This data specifically for sickle cell, and you can see that the comfort level with doing transplants, you kind of had a few in the 90s where people were still figuring out how to get things done, but definitely as the 2000s rolled on and more recently, the understanding that transplant can be a benefit for people with hemoglobin disorders has risen. And so the survival is quite good because you're not trying to fix a cancer. You're trying to just fix the red blood cells. So the immune cells, the white blood cells are fine. And so most people with hemoglobin disorders, they have better outcomes with transplant than maybe if somebody had leukemia, for instance. We have several years of experience now doing transplants and hemoglobin disorders, and to the point where it is now acceptable for children to get a transplant, and you don't need to like justify it too much. Most people understand that transplant from a match-related donor can be good. So what's the problem? Well, the problem is not everybody has a match in their family. In fact, about 1 in 10 individuals have a match in their family. And when you look at the other ways to get transplant, they're still being studied, such as somebody who matches you that's not in your family, or maybe a parent or a person that's a half match. Those things are getting more research behind them, and there's some exciting work being done in that space as well. But it is a limitation. And then we mentioned the chemotherapy and the fact that you're always worried that, am I going to reject? Just like when you talk about any kind of transplant, you can also reject a bone marrow transplant. And then there can be an issue where there's a disagreement between the donor cells and your body, and there's something called graft versus host disease. Those are things that are very scary risk when it comes to thinking about transplant. And
Dr.
then if you
Fisipe,
already had, oh, yes.
with about 3 more minutes, just give me
Oh,
your minute
thank
warning.
you. Yes. And if you already had damage to your body from sickle cell disease or thalassemia, those are things that can also play a role. And the older you are, the more risky the procedures tend to be. So then this brings us to the concept of why gene therapy was so exciting and why all of us were like, tell us more, tell us more. Well, gene therapy is still a transplant. However, the difference is we are using your own body. So we collect the cells from you first, and the processing step is fixing the problem. And so for thalassemia and sickle cell, they're slightly different, which I'll get to. And then you give them back to your body, but it's still the same problem. You have to get rid of the old cells. And so right now, the only way to do that is still through chemotherapy. So what are the different approaches? Well, gene addition can work for both, where you add a good gene. You still have your abnormal stuff going on, your mutation, but the good gene kind of takes over. You can do a change to help the fetal hemoglobin come up on its own. And that change right now, the most common way that many people have heard of and the approved way, which I'll discuss, is by using CRISPR, basically a set of scissors to get rid of the thing that keeps fetal hemoglobin from being made. So for thalassemia in the United States, 2 gene therapy approaches have been approved. This is different depending on what country you're in. I believe in UK only 1 type has been approved. But the 2 types that are approved right now in the United States are something called Beti-cel or exa-cel. One of them is a gene addition approach, and the other one is a gene editing with those scissors approach. right now for the addition approach for thalassemia, it is open for children, and in the trials, the children were as young as age 4, children and adults with transfusion-dependent thalassemia. And this is the data from their results. So that's why it got approval. On the other hand, the gene editing approach is only approved in 12 and up, and it because of the youngest age that they used, and they are still studying in younger ages. For sickle cell, there's also 2 gene therapies approved in the United States. Both of them were approved in ages 12 and up, and they're both getting more studies. The story is a little more complicated with sickle cell. The data from thalassemia was quite great, and most people did very well. Sickle cell, most people did very well as also. However, in the early versions of the lovo-cel clinical trials, there were a few people that developed a cancer, and it did not seem related to the product, but it was something the FDA felt was important for people to know. And then there's some other things about your genetics, and here's the alpha thalassemia coming back, that play a role in whether or not lovo-cel is the right option for you. Now, having said this, both diseases, both disorders have lots of other companies looking at gene therapy. And so we're going to learn more about this as the years go on. I just want to end with this, and I think Ms. Calabria will probably pick up on this part. Patient perception of risk and the real life implications is quite important. So they want their providers to be transparent with them. They want to know the side effects of therapy, but there's more than just the drug side effects. There's also things that are considered more hidden, like the cost, impact on fertility and reproductive health, their identity, and mental health. So those are things we want to make sure that this world of curative therapies keeps in mind. And so it's important to keep the patient community voice at the table. And I'm going to skip over that part. This is the last slide because this is the only way that we'll make progress, because it's not a sure thing that everybody wants a curative approach for various reasons. And so I think we're just in the stage of discovery, but it's quite an exciting time to be discussing this. So I'll end here and let me pass on to Ms. Calabria.
Thank you for that, Dr. Fasipe. Really appreciate that fulsome conversation. But keeping right on time, as you mentioned, next we have delivering her perspective is Bessie Calabria, who is a thriving beta thalassemia major patient, who is a president of the Thalassemia Foundation of Canada and a board member, pardon me, and board member of the Thalassemia International Federation. She's passionate about patient advocacy and education and believes that knowledge is a powerful way to improve patient outcomes. She's a graduate of Queen's University and has worked in leadership roles in the financial services industry for over 25 plus years. Most of all, she loves spending time with her family, friends, and the thalassemia community. Over to you, Bessie. We're on mute, by the way.
That would help.
You know that's gonna happen.
Yes, of course. And will you be sharing the presentation I sent over, or?
Yeah, so my colleague Dapple can pull that up. In the interim, I
Perfect.
want to let folks know that we will be having a poll at the 5 minute point mark for the conversation today. I should have mentioned that earlier. And as well, if you have any questions, or feel free to chat by way of the Q&A feature or the chat feature as well. So please don't be shy. It's a great opportunity to connect with your co-participants. And we'll be accepting questions all throughout the session. And then, like, once again, just know that we will be ending promptly at 11:20. And Dr. Fasipe will probably have to leave at 11 o'clock promptly. So if there are any questions for her, please do enter them in the chat now.
Okay, great. Thanks for that. So just
No
while we're
problem.
waiting for the presentation to come up, I just wanted to thank Dr. Fasipe for that really great overview. There is a few things I have in my presentation that are similar, so I'll try to just kind of skip over those items so we can have some more time for Q&A today, which I know is really important to folks. So I have no conflicts to declare. If we can just move to the first slide. So this really, I'm pleased to be joining, all of you and my co-speakers today, because this is a really important topic for the thalassemia community. I'll be speaking, about the curative treatments predominantly from a patient's perspective. But as you're aware, we have a few doctors on the panel. So if anyone has any detailed medical questions, we should be able to answer those as well. Um, this is very similar to what we've already talked about at the top of the session, but I really just want to emphasize, the evolution of curative therapies for thalassemia has been very slow. We have, as Dr. Fasipe mentioned, we have bone marrow transplantation that has been available for some time now, probably more than 3 decades. Again, I think, the challenges with bone marrow transplant has been the availability of an identical match donor, and some of the concerns that families have had when that isn't the case, and not a lot of families have been wanting to take any risk around half match donor, just because thalassemia is a treatable disease. So I think, I put on the slide here, thalassemia is finally sexy. And I say that because for many years, it seemed for our community that it was really hard to generate interest in thalassemia research, in particular in Canada, where the numbers are quite low or lower than some of the other countries. And I think that just hasn't gotten us the attraction of some of these more curative therapies that the population has been wanting for quite some time. I know Dr. Fasipe had mentioned that there are a couple of approved gene therapies. We're in the middle of an exciting time for these new curative therapies coming into the market. Some of the therapies that are approved in the US and other countries are not yet approved in Canada. However, we do have a gene therapy using the CRISPR-Cas9 technology that Dr. Fasipe mentioned, that has filed for and received Health Canada approval and is just going through the Canadian Drug Agency process for recommendation of reimbursement. So it's a really exciting time because we're expecting some news on that in the next month. And I think, these therapies are not just, needed for patients who choose to try to cure their thalassemia, but we also have some patients that have some urgent needs due to issues with some of the conventional thalassemia treatments that are for lack of a better term, chomping at the bit for these approvals to come through and for these treatments to become available and accessible. And we'll talk a little bit about that on the next slide. So if we can move to the next slide. So earlier this year, the Thalassemia Foundation requested some patient feedback regarding new curative therapies through a national survey. It was really clear to us from the responses that, a curative therapy, people were really looking like at the holy grail of treatments, seeing it as a holy grail of treatment. Across all of the different survey responses, if we were to summarize them, I think the outcome and benefit most expected from these treatments was removing the need for thalassemia patients to be dependent on transfusion and all the consequent improvement in quality of life that would result from the lack of transfusions needed. Things like, the going to get transfusions, the iron chelation that's needed because of the iron buildup from the transfusions, the overall general stress of managing the disease, which is quite a burden on our patients. No transfusions also means fewer complications from iron overload, time spent in hospital, taking time off work, being away from family, and then just in general feeling healthier and participating in activities that they may have not been able to participate in because of their illness or feeling anemic prior to transfusion. And I think, it was described well by one of the patients that a potential cure would free patients from, you know, the ball and chain that was given to them at diagnosis, and they could feel like they were gaining control over their lives. We got a ton of feedback, but I thought I'd share just a few example responses we received, which is, what I expect is to receive fewer transfusions or none at all, and to have few side effects from the gene therapy. And also someone else indicated they would expect is a better quality of life without so many appointments, monitoring iron, is kept at a safe level and no damage being done to vital organs. And, there was a long list of feedback, but they all had the same general theme of hope for just overall a better quality of life. If we can go to the next slide. I thought,
Bessie, you have about 5 more minutes, just letting you know.
yeah, this is my,
Perfect.
this is my last slide. So
Oh, perfect.
should be
Perfect.
good.
Back to you.
Short and sweet. In terms of what patients perceive the risk of curative therapies to be, people generally understood bone marrow transplant, and the overall and disease-free survival ranges. I think folks generally understood there were risk of graft versus host disease, which was mentioned in the earlier session, and also the morbidity that is associated with that type of reaction to the bone marrow transplant, and that creates a lot of hesitation in the population. In Canada, again, where access to safe blood is available, access to treatment is available, and it is a disease that can be effectively managed with the right comprehensive care. For gene therapies, I think there's natural resistance to anything new. Patients are concerned with things like the theoretical risks of genotoxicity due to like manipulating the genes. Um, Obviously they're concerned about morbidity and serious illness and infections, and then the long-term risks and side effects that are not yet observed or understood with these types of newer therapies. Obviously, in Canada, and I'm sure other places in the world, we're considered about fair access to the treatment, and also concerned about the financial burden of treatment. Will it be covered by the government? Will all the associated expenses for the families be covered, etc.? And for both, I think bone marrow and gene therapy, the general concern patients have is that it's either not successful now or it loses effectiveness over time. We do know of someone in our population who had a bone marrow transplant when they were quite young. And then, some decades later, started to have prevalence of the thalassemia gene, and actually require a second bone marrow transplant. So I think that is a valid concern that patients have. Also, as mentioned, using chemotherapy drugs is a concern, and the impacts that it will have on their body and long-term health, including, losing the ability to naturally conceive children. So those are some of the things we hear quite regularly. And I think then there's just some practical concerns that folks have with time off needed from their studies or from work to undergo the treatment, the lengthy hospital stay, what type of family support or better yet travel the gene therapy treatment and recovery will have on the family, and then concern around logistical travel to treatment centers, both during and post treatment for any monitoring and follow up. Okay, and I think that's it for me. I know we'll see if there are any questions later in the session.
Bessie, talk about timing. I mean, well done. Thank you so much for that fulsome conversation, that fulsome presentation. Folks, as Bessie mentioned, if you have any questions, please use the Q&A feature or the chat, but we'll also have a prescribed time toward the end at 11:10 for other additional questions. So that brings us to our final, but definitely not least, speaker. We have Dr. Ahmad Kabil Khalib, who's a medical doctor specializing in psychiatry and works for the Ministry of Health in Malaysia. He's both a clinician and a hospital administrator. Dr. Khalib has been actively involved in the Hemophilia Society of Malaysia for more than 40 years and has previously served as an executive committee member. He's experienced and witnessed the progress of hemophilia management in Malaysia, as well as the achievements of and challenges faced by people living with hemophilia in Malaysia. So, without further ado, I'm going to pass the virtual microphone over to you, Dr. Kabil.
Thank you very much, Mr. Hines. And hi, everybody, my fellow presenters and all the participants. I'll start off by sharing my slides.
Perfect.
Are we
They're
good to go?
live. Yes.
Great, thank you. Right, it's near midnight in Malaysia, and it's a Friday night. So great timing.
Thank you for being here. We appreciate you.
Most welcome, my pleasure. So I'll be discussing on hemophilia, and I'll be coming from two perspectives. One, as a person with hemophilia, I was born with hemophilia in 1975, and my factor level is less than 1%, which means that I have severe hemophilia. So it was a challenging time growing up in Malaysia with hemophilia. As a child, my ambition was to become a firefighter, believe it or not. And when I became an adult, I thought my ambition was amusing. Because of course, to be a firefighter, I have to be strong and be able to lift people and save people from fires, etc. So I became a doctor instead, and I ended up being a psychiatrist. I really enjoy my work. So my perspectives will be mainly as a person with hemophilia. I have two other brothers who have hemophilia as well. One is a lawyer, one is in IT. As a doctor, I choose not to specialize in hematology because I wanted it to be something different. Hemophilia is personal, psychiatry is professional for me. Right. Let's have a look at the history of treatment for hemophilia. In the 1950s, we only had fresh frozen plasma. I went through that, been there. And then we had cryoprecipitate for hemophilia A. And then we had cloning of the genes, which was in the 1980s, both for hemophilia, for factor 8 and factor 9. Then we had recombinant therapy for factor 8 and factor 9. And subsequently, slowly but surely, we are developing the gene therapies for both hemophilia A and hemophilia B. So that's really exciting news. We have been on this journey for many, many years. When I was in medical school, I went to medical school in Auckland, New Zealand. When I was in second year, I had the opportunity to do a research write-up. So I grabbed the opportunity to do a write-up on gene therapy for hemophilia. Mind you, this was 28 years ago. So I was really looking forward to a cure for myself and my fellow brothers and sisters with hemophilia. So I did a pretty good write-up, I have to say. I was really happy to see the outcome of my write-up. And 28 years on, we are seeing the actual fruit from the many years of research done by various scientists across the globe. So let's have a look how much we have progressed. For hemophilia B, now we have gene therapy. This was published in the New England Journal of Medicine last year in February 2023. And what about hemophilia A? Yes, we have that as well. This is from the US FDA website in June last year. FDA approves first gene therapy for severe hemophilia A. So yeah, it does look promising. So how is it done? So we have the virus which we use as the vector, right? So there are various types of approaches in gene therapy. So we have the adeno-associated virus being the vector or the vehicle to transport the genetic material to the liver cells through an infusion. And when this enters the liver cells, it stimulates the liver cells to produce the clotting factors, whether it's factor 8 or factor 9. And research has shown that we are able to have sustained levels of clotting activity in the patients over 3 to 5 years. But we don't know yet how long it will last in the body. So there is findings that it might decline over the years. So whether we can say it as curative, yes, probably partially, at least at the time. And hopefully in the future, we can have sustained levels of factor 8 and factor 9 activities in the patients for lifelong curative treatment for hemophilia. So what are the benefits of curative therapies? Well, obviously, patients like us can live life to the fullest, and probably I should still pursue my dream of becoming a firefighter. And it's a great motivation to our little boys and girls who are living with hemophilia. They see the light at the end of the tunnel. They don't have to go through the challenges and difficulties that the older generation has gone through. At the same time, the curative therapy for hemophilia brings hope for other disorders as well. So it's not just hemophilia. If it can be done for hemophilia, I'm sure it can be done for other diseases as well. So it brings hope to the whole world that more diseases can be treated with gene therapy. But at the same time, we have yet to find a solution of not passing on the genes to the next generation. As we know, hemophilia is on the X chromosome. So it is being passed from generation to generation. With the current treatment approach using gene therapy, it can provide sustained levels in that person, but it won't be passed on to the next generation. So the offsprings will be needing therapy as well, until we find another method that can provide permanent cure for hemophilia. So hopefully that will come within our generation. At the same time, we are aware of the various risks of curative therapies. There are the biological risks as well as the ethical concerns. For the biological risks, at the moment, from what we see, the treatments available now are deemed to be safe. But we don't know what will happen in the future, whether there'll be genetic mutations or toxicity to the cells, or immune systems reacting abnormally to the therapy that is given. So these are some of the uncertainties that we face, and we would like to see how our patients who have undergone the therapy succeed in maintaining their level of health. Apart from the biological risks, we are also aware of the ethical concerns. One is the cost, whether the therapy is only available in certain parts of the world, whether only the wealthy are able to get access to such therapies, and whether insurance will cover it. And if it has become a curative therapy in certain parts of the world, what about those who are unable to be treated or not yet being able to access the treatment, whether will be seen as different from those who have been cured? So those are some of the ethical concerns which we foresee. And in certain parts of the world, people might be pretty reserved about genetic therapy changing your genes. So we have to have the hemophilia societies to advocate, to really explain to the hemophilia community on the risks and benefits of the gene therapies for hemophilia. But having been through the hardships and challenges of growing through my hemophilia experience, hemophilia actually helped shape my personality. I'm sure many of us here share this. Difficulties we go through has actually made us stronger as a person. We build a sense of patience, a sheer determination to get on with life. We are resilient. We have empathy for others. And at the same time, we have great gratitude for our treaters, for the scientists who have worked so hard to help us. And at the same time, those who have made it well in their lives, we become a role model for the others to look up to and share the strength and motivation to carry on with their lives. So it's great to have everybody here today. I hope my short sharing here will be inspirational to all. Thank you so much.
No, all the thanks to you. I honestly, having these perspectives are so invaluable. It helps folks to recognize that in many shapes and forms, there's ways to have an impact. So thank you to all three of our presenters, and thank you for closing us off, Dr. Kabir, on that very heartfelt note. So folks, it's now time for Q&A, as Bessie and folks mentioned earlier throughout the presentation. So please do enter your questions in the Q&A section, or if you have any questions, feel free to use the chat. And for those and those who are motivated, you can also raise your hand perhaps, and we can find a way to take you off mute so you can ask your question orally. In the interim, I do have a question maybe all three of you can respond to, or all two of you, sorry. Back to your point about the impact, not only that the disease can have on your life, but how you can have an impact on the disease. Maybe starting with you, Bessie, you do a number of different investments of your time to help build awareness and calls to action for folks. Are there more you think that the system can do, or more that folks can kind of perhaps contribute in order to make sure the awareness of thalassemia is growing?
Yeah, thank you for that. I think, you know, for those of us, I hate to use the word term older, but experienced patients who have been along the journey when, you know, certain treatments weren't even available, or the treatments that were available were very onerous, long, like nightly infusions of iron chelation medication, stuff like that. You know, for those who have been able to be resilient and still are doing well today. I mean, personally, I've always felt just a sense of kind of obligation to act as a voice for other patients who are either less experienced, staying away from the the older label, who are either less experienced or who maybe aren't doing as well, right? For a variety of reasons. You know, Dr. Gabil talked a little bit about like the psychosocial aspects of the disease, and it isn't something that all people are able to be resilient and to thrive despite having thalassemia. There are still a lot of our patient population that are struggling with the day-to-day management. So I feel blessed myself personally, to be where I am today. And so, yes, there's an obligation to help further the work of like the different foundations, to be involved in GANSID and other international federations supporting this patient population. And also to be a voice. And what I found is when we did that survey earlier this year, people want to share their voices, right? And their experiences and their concerns and their wish lists. And I think it's really important patients have a mechanism to share their voice, and that they do take the time to share it, because that type of information, in that particular example, was used to help support advocating for the accessibility of gene therapies should they be approved by Health Canada. And I think, the voice is, really important, right, for the decision makers, to make those decisions on behalf of our population. I'm
Beautifully
not sure if
said,
that
Bessie.
answers your question,
It,
but
it did, because the question wasn't very clear in my own end, so you did a fantastic job. And I'm just here trying to coalesce all the information you've all delivered, and I'm thinking back to your point, Bessie, about the psychosocial impacts, not only of the inaccessibility, but for those folks who have had the gene therapy, and then you mentioned that earlier case where the young woman had it at a young age, and then over the years it came
yeah.
back, and the luxury of having someone like Dr. Kabil on the line with your psychiatry background. Is there any type of approaches, or even some best practices, Dr. Kabul, you can share with the group in and around, how to be, preventative or protective of your whole psychosocial kind of baselines, either pre, post, and during receipt of these treatments?
Yeah, I think for the younger kids, parental roles are very important, how to shape the growing children. Sometimes we have to balance that between being overprotective and being too open for them to try out new things, because when we are too permissive, they might get injured and have consequences and affect their academic achievements. But if we are too protective, they might grow up being timid and with low self-esteem individuals. And we have to balance that. But with the new therapies that we have, those who are able to access those, that would be great. But at the same time, as what Bessie mentioned, there's still some people who are not yet on board. Even in the hemophilia community in Malaysia, we still have people who don't have yet the confidence to self-infuse at home. I started self-infusing when I was 10. So it saved me a lot of school missing days, because I can just come home and infuse myself. But now in 2024, we still have kids who miss schools regularly because they are not confident enough to self-infuse. So yeah, it's a long way to go.
Sorry, here it is. The Zoom bingo, I myself was on mute. So thank you for that response, Dr. Kabil. You're right. We still do have some ways to go, and there's more work to be done on, identifying what's the best approach for each individual. And I want to talk a bit more about the accessibility question. And I know we're in different settings, so maybe you can each respond to this, but it's one thing to hear about these curative therapies, and then another thing when you come up against a pay barrier or some type of political or policy reason why you can't access it. in those moments, do you have any words of encouragement to share with folks on the line, or some of the thinking and some of the approaches you use to help, you know, support people in your respective communities? Maybe Bessie, we'll start with you.
Yeah, I can start just to say, back to what I was saying before, which is it's really important for patients to lend their voices to greater efforts by different organizations to, um, to create interest in companies filing for approvals in the various jurisdictions, to lend their voices to ensure that policymakers, when they're making decisions, they understand what the disease is, whether it's thalassemia or hemophilia, and what the potential benefits would be, not just to the patients, but what we tried to do, in our submission is also to talk about the burden of healthcare for a particular, a lifelong burden of healthcare, and then all the costs associated with that to a policymaker, right? So when you're looking at like a multi-million-dollar price tag of a gene therapy versus a lifelong experience of treatments, it doesn't look as bad as it does if you're just looking at it in isolation. So I just think it's really important patients, to get involved and families to get involved and to advocate for accessibility, right?
Perfect. Dr. Kabir?
Yeah, I totally agree. I think it's a big role for the societies, the hemophilia societies in particular, from the hemophilia perspective, to advocate for the modern therapies. And despite the high cost that it might incur, but we have in scientific journals showing that despite the high cost of curative therapies, it is still more cost effective compared to lifelong prophylaxis or on-demand therapy. And that is not even considering the quality of life of the patients. So yeah, we should go for it if possible. Yeah.
Perfect. Folks, we're going to be launching the poll, as I mentioned earlier during the session. So please do submit your feedback by virtue of the poll, so we can carry forward any of your suggestions and incorporate them. There's one question that's come through in the Q&A, and it reads, what is the fate of patients with hemophilia in countries where they have not been able to afford gene therapy and are currently relying on donations, or donations from different nations, especially with the current shift from factor concentration to more of gene therapy specifically for hemophilia patients. So I guess it's more or less just trying to understand the burden of illness and what that means for people who can't afford gene therapy. I don't know if Dr. Kabil, you'd be able to respond to that.
I'm not too sure which countries have moved on from fresh frozen plasma and cryoprecipitate, moving on to factor concentrates and recombinant therapies. But I guess most of the world are now using factor concentrates at least. But yeah, I can't comment much though.
Right.
We have to make do with what we have. But having a session like this, be an international online session, people can actually see what is available to the other parts of the world, and how we can help to engage our stakeholders to push and advocate for our society. Yeah, hopefully we can
Yes.
move forward.
Great question. A great response. I'm not seeing any other questions come through in the chat, folks. Please do take full advantage of our presenters here. So if you do have any questions or thoughts, feel free to submit them now, as we'll be closing shortly. I will take full advantage if no one actually wants to submit a question. But I'll give folks just a couple seconds to think through anything they might have to ask before closing things out with a final question. Okay, question for both of you. You both come from completely different subject areas. but you mentioned it really clearly that this is something that there's an intimate personal connection. And I think you presented it really well, Dr. Kabil. Like professionally, you're a psychiatrist, but personally, you're living with the disorder. And Bessie, same likewise for you. Professionally, you're in finance, but personally, you're living with thalassemia. How are you able to carry both of those identities and do it so well?
I don't
So if you
sleep.
go,
I don't know. Um, they are very obviously different fields. But running a charitable organization requires a level of business acumen, right? And it requires, ability to um, you know, to correspond in a way that evokes action. It requires, an understanding of financials and budgeting and negotiation and all these other skills that I think, patients may think, okay, I can't contribute to a particular foundation or organization because, I'm in marketing but foundations need great marketing skills, right? So I think you know they're very different, but there is some soft skills that are transferable between different occupations and the work of these associations and foundations. And then it's just, it's a passion project, right? It's none of
I
us
love it.
do it. At least in Canada, none of us are paid to do it. So it's a labor of love. And honestly, I think one of the other unexpected benefits when I started 18 years ago was the close relationships that would be built within the community, and what a source of strength those are personally to me when I have, I'm going through something specific, or, that's related to thalassemia. So I think like it just encourages, you know, those close relationships to be built. And, from a psychosocial perspective, those are so important for patients to have others that they can talk to about these types of issues that are unique to one patient group or another.
Great response. Dr. Kabil, closing thoughts?
Well, for me, although I keep my professional life and personal life separate, but at the same time, it's very much linked because my professional success is a motivator for the younger boys. So I would like to have that role model, to keep them in school, and keep fighting and be successful like the others. We can do it.
We can do it. Beautiful way to close up the session. I see that the love is pouring in from participants. Thank you all so much. That draws to a close our session on benefits and risks of curative therapies and inherited blood disorders. A big, big, heartfelt, warm thank you to Bessie Calabria, Dr. Ahmad Kambil, and Dr. Titi Fasipe for your invaluable contribution and just great overall knowledge and insight that you're able to share today. Folks, we're going to be moving on to a break from 11:25 to 11:45, and then we'll be kicking off our simultaneous sessions in the afternoon from 11:55 a.m. at Eastern Daylight Time to 12:55 p.m. So please enjoy your break. Thank you all once again, and we look forward to seeing you later on today.
Thank you, Delaney. Thank
Thank
you.
you.
So
Take care,
much.
all. Bye.